about so far?
No, sir.
Okay. So hopefully you all find that will actually make life a little easier for you, and certainly easier on the pocketbook, hopefully. Okay. Well, with that in mind, let's go ahead and pivot into the lecture topics that I want to get through today. And we'll be talking, I'm not going to really talk a whole lot about vascular access in lecture today, because you have the videos that were already due, and that's what we'll be focusing on in lab. And vascular access and venipuncture is really highly psychomotor anyway. But what I want to do is I want to talk a little bit about some content that I probably should have focused on earlier, and that is some additional antidysrhythmics. And there is another agent. So you should all be familiar with the standard von Williams classes, right? Class 1 are the sodium channel blockers, and 2 are the beta blockers, 3 are the potassium channel blockers, 4 are the calcium channel blockers, and then you've got the miscellaneous agents. We talked about adenosine, we talked about digoxin, but I do want to just mention magnesium, because magnesium is a drug that has lots of different roles, lots of different indications, not only in the hospital, but in the pre-hospital context. We could potentially use magnesium sulfate for many different things. And so what I want to do is I just want to talk about some of the other things that magnesium sulfate can be used for. So let me just go in, screencast here, go into my notes. All right, excellent. So let's talk about magnesium sulfate. So magnesium sulfate does have antidysrhythmic properties, and we know that magnesium plays a very important role in the movement of calcium ions within not only myocytes, heart cells, but within neurons and other cells as well. So it modulates calcium ion flow, and that allows it to function as an antidysrhythmic. Specifically, I want you to focus on a potentially life-threatening rhythm known as torsade de pointe, or TDP. And torsade de pointe is a special form of ventricular tachycardia. It is what we call a polymorphic ventricular tachycardia, and we'll talk all about that in the next class. But magnesium sulfate is one of the pharmaceutical agents that we use to treat torsade de pointe. In fact, many of the agents that we would typically use to treat ventricular tachycardia can actually cause torsade de pointe, because a big part of torsade de pointe is an increase in something called the QT interval, or the QTI. And when the QT interval increases, that increases a risk for torsade de pointe and life-threatening ventricular dysrhythmias in general. And so any agent that widens the QRS complex or prolongs depolarization or repolarization is going to increase the risk of torsade de pointe. So the class 1A and 1C agents, and the class 3 agents in particular, but many other drugs, many of the antiemetics, some of the antihistamines, a large number of prescribed medications as well, can impact the QT interval. So this is a very common side effect. So even things like Zofran or ondansetron, promethazine, right, droperidol and napsine, right, some of these other agents that we occasionally run into and even administer can cause elevated QT interval. So that's one of the other major roles for magnesium sulfate. Magnesium sulfate also, due to its ability to modulate calcium ion flow, can act as a smooth muscle relaxer. And so magnesium sulfate can also be considered as a secondary agent for bronchospasm. So if somebody is having bronchospasm and you've administered your frontline agents, your sympathomimetics, albuterol, for example, right, and they're not responding, you may consider adding magnesium sulfate into the mix as well. In addition to that, magnesium sulfate is sometimes or often used to treat PIH, pregnancy-induced hypertension, specifically more life-threatening forms of pregnancy-induced hypertension, pre-eclampsia and eclampsia. And the doses for pre-eclampsia and eclampsia tend to be much higher than the doses for torsades or bronchospasm, right? You're looking at the 1 to 2 gram range. Mix 1 to 2 grams in 50 to 100 milliliters and give it over 10 to 15 minutes. It's kind of your standard dose. But with preeclampsia or eclampsia, you may need to give large doses, 2, 3, 4 grams, and then follow that up with a continuous infusion of magnesium, 1 to 4 grams an hour, titrating up and down to patient response. And then finally, magnesium sulfate may also be given as what's known as a tocolytic. And does anyone know what a tocolytic is? Anyone ever heard of that term? A tocolytic.
No.
No, okay. So lytic, right? Lyse, break up, stop, prevent. So toco refers to labor. So tocolytics are drugs that stop labor. They are against labor. All right. So if somebody goes into labor, and particularly preterm labor, and we want to stop that labor from progressing, tocolytic drugs are used, and magnesium sulfate can act as a tocolytic as well. So magnesium sulfate has many different roles. And of course, we talked about what you need to monitor with magnesium, right? The patient's blood pressure, because it can cause hypotension. We need to monitor the patient's deep tendon reflexes, because it can suppress deep tendon reflexes. And then we need to closely monitor the patient's respiratory rate and their depth of breathing or their tidal volume. We don't want them to hypoventilate. And does anyone know what the antidote is to a magnesium sulfate overdose? So someone has a massive overdose of mag sulfate. What is the antidote?
Calcium.
Yep, good. So calcium, gluconate or chloride, right? So calcium also has other roles, right? Its primary role, for at least for us, is its use in treating life-threatening hyperkalemia, but it can also have other roles. Okay, good. So on the lines of labor and delivery, since this is just a good segue, let's just talk about some additional drugs that we may administer or come across. And so let's just talk about some additional tocolytics. And remember, we talked about the beta agonists. So these agonize beta, specifically beta 2 receptors. And where are beta 2 receptors located? Okay, in smooth muscle within the lungs. Where else?
the GI tract and the uterine line.
Yeah, and the other major area is in the uterus, because that's basically what the uterus is. The uterus is a muscular bag. It's a bag of smooth muscle. So certain beta-2 agonists can have substantial action on that smooth muscle in the uterus. And remember, beta-2 agonists, are they inhibitory or excitatory when it comes to smooth muscle?
Inhibitory.
They're inhibitory, yeah. So remember, beta-2 agonists are also referred to as sympathomimetics. They mimic the sympathetic nervous system, and the sympathetic nervous system is inhibitory on smooth muscle in the lungs and the uterus, and so it causes that muscle to relax. And one of the most common beta-2 agonists that's used as a tocolytic is something called terbutaline, also known as brethine, is its trade name, brethine. And occasionally we will also administer terbutaline to patients having bronchospasm, hence the term brethine, right? It can be administered subcutaneously. So occasionally you may see people receiving terbutaline for bronchospasm as well, but it is often used for its tocolytic properties. All right. Now, there are also some drugs that enhance contraction of muscle in the uterus. So why would we want to cause the uterus to contract?
Hemorrhaging.
Bleeding.
Yeah, so the primary use for our purposes for these drugs is to cause the uterus to contract and to control bleeding, specifically to control postpartum hemorrhage. And that is generally defined as greater than 500 milliliter blood loss in the few hours following birth, right? Now, the immediate action drill for controlling postpartum hemorrhage is going to be uterine, or what we call fundal massage, right? And you identify the fundus of the uterus, you massage it, you stimulate it, and make it contract. And when that fails to work, this is when we will administer something called oxytocin, also known as Pitocin. This is actually a hormone and a neurotransmitter that is created in our body. As a neurotransmitter, it plays an important role in love and bonding, whereas as a hormone, oxytocin plays a very important role in causing the uterus to contract. Oxytocin is sometimes given to do what's called an induction. And what is an induction? When I say oxytocin is used as an inductive agent, what do I mean there?
To start labor.
Yeah. So we'll sometimes give it to cause labor, right? So it is the opposite of a tocolytic. Now, we would not be administering that as paramedics. That's not our role typically, to induce labor. The primary indication for oxytocin for our purposes is a part of the treatment plan for postpartum hemorrhage that does not respond to fundal massage. Excellent. All right. There's also another agent I want to talk about. This is moving away from the peripartum scenario, i.e. labor and delivery. And I just want to talk about it because it is an agent that is in our scope of practice, and we could potentially carry it and administer it. And that is something called thymine. Does anyone know what thymine is?
It's a
Isn't
B
it?
vitamin.
Yep. It is actually vitamin B1. And what's so important about thymine? I believe you all had to do a drug card on this too, so.
I know in our scope of practice, we give it to malnourished alcoholics.
So yeah, those are some of the indications, right? So if someone is severely malnourished. All right. They don't necessarily have to be an alcoholic either, right? This is someone who's very malnourished, and this tends to be very common in people who are alcoholics due to the load that it puts on the liver. And this, it kind of goes back to what the importance of thymine is. And thymine is unique in that we cannot make thymine. Our body cannot make it. So it is an essential nutrient. Just like when we talked about essential versus non-essential amino acids. And a non-essential amino acid is an amino acid that our body can synthesize, but an essential amino acid is something that we have to get from our diet. Well, thymine is not amino acid, but it is an essential vitamin or a micronutrient, and that we have to get it from our diet. And the reason that it is important, it is a cofactor. So it actually helps certain enzymes function. It's not an enzyme itself, but it acts as a cofactor for certain enzymes. Specifically, enzymes involved in ATP production, like the production of pyruvate. Right, when talking about glycolysis going into the Krebs cycle, there are enzymes there, and those enzymes will not function if we do not have adequate stores of B vitamins. And so this means that if someone is incredibly malnourished, or they're a chronic alcoholic that's malnourished, and they've lost their stores of thymine in the liver, they cannot metabolize carbohydrates like glucose and certain amino acids very well. And that has some consequences. And those consequences tend to impact organs that are highly dependent on glucose for energy, specifically the brain. And the brain is a fairly unique organ in that sense, in that the brain really does require glucose, whereas a lot of your other organs, like your heart and your muscles, are not as heavily dependent on glucose because they are very good at using fatty acids for energy, right? So fatty acids can get broken down through beta oxidation and converted into intermediate molecules that can be fed into the Krebs cycle. And that occurs very easily in those tissues. The brain, not so much, right? In fact, glucose is so important that the neurons of your brain do not require insulin. They're one of the few areas of your body where you don't need insulin. So glucose can freely diffuse into the neurons without having insulin. Insulin does not need to be present to facilitate the diffusion of glucose through transporters like we see in other cells, right? So this is why, like a type 1 diabetic, somebody who is a type 1 diabetic, who is not making insulin, but their blood sugar is very high. That's why their brain can still function, because glucose is still able to get into their brain. It's just not able to get into other tissues. And so those tissues have to revert to fatty catabolism for energy production. And then all the consequences that come with that, right? The creation of ketone bodies, creation of organic acids, the dehydration that comes with the hyperosmolar effects of the glucose, and so on. Now, when we have a lack of vitamin B1 or thiamine, these neurons in the brain are very sensitive to this, and there's actually a condition that can occur. It's not very common, and you may have learned this as intermediates, and I think we don't teach this very well, because people come off thinking, oh, it'll happen instantaneously if you give a severely malnourished person or a chronic alcoholic, if you give them glucose because they need it, they will instantly go into this problem. And that's not really how it works. It takes hours to days to develop. And so you have a pretty decent window to treat or to prevent and treat this condition from occurring. But this condition is something known as Wernickes encephalopathy. So let's just talk about that real quickly. Wernickes encephalopathy. So Wernickes encephalopathy, it presents with a classic triad of findings. And that triad includes confusion. Patient becomes very confused. Ataxia. All right. Ataxia is a gait problem. It's a problem with walking. It is unsteady gait. And the gait widens out, and the patient and is sometimes referred to as the quote unquote drunk walk, because that's kind of what it looks like. And often in being drunk can cause ataxia as well, because ethanol will poison the cerebellum, the part of your brain that is responsible for fine motor coordination. But this ataxia is caused by the brain's inability to properly utilize glucose. So you got confusion, ataxia, and then you have ocular anomalies or abnormalities. So things like nystagmus. So those are the classic things that occur. And there is actually a center within your brain. It's called the Wernickes center. And it is in the left temporal lobe. And it is known as Wernickes center. And what it is responsible for doing, it is responsible in part for receiving language and making sense of it. So language comes in and it gets interpreted. There's another center in your brain called Broca's, where it is involved in sending language out. All right. So with Wernickes center, it is all about receiving, about understanding the language that's coming in. And so when that area gets damaged, sometimes following Wernickes encephalopathy, right, you can actually have something called a receptive aphasia that develops. Aphasia with an S, not G. So aphasia with a G has to do with an inability to swallow, which is a cranial nerve problem, whereas aphasia is a language problem. And there are two major types of aphasia. There's receptive. That means you cannot understand language coming in. And there's also something called expressive. you cannot get proper language out. So Wernickes is all about receiving, and that can produce a receptive aphasia that can occur. Now, alongside Wernickes encephalopathy, about 80 to 90% of the time, if somebody has Wernickes encephalopathy, they will also develop a concomitant co-occurring problem known as Korsakoff syndrome. So this is often referred to as Wernickes-Korsakoff syndrome. But Korsakoff syndrome is its own thing, but it happens, it's very common, it's like 80–90% of the time. And this is where people also develop severe memory impairment. So to prevent this from occurring in people that are at high risk for developing Wernickes and Korsakoff syndrome, it is recommended that we supplement people with thiamine. So if you have someone who's very malnourished, right, this could be someone who's very cachexic in a nursing home, maybe they're not eating. This could be someone who's been starving. We may end up dealing with this. This may be a problem in Europe. You've got lots of refugees that are coming out of various cities in Ukraine, and many of those people may have been without food, adequate resources for an extended period of time. We're going on about 20 days now into this, and so we could see this occurring in that kind of environment as well. And so it is recommended that people that are at risk for thiamine deficiency receive thiamine, and it's pretty easy to administer. You just administer it as a slow IV push. It's generally very safe, and its side effects profile is generally pretty good. All right. So are there any questions over any of that? Everybody okay with all that? All right. Well, excellent. So the next thing that I want to do is I want to now spend some time talking about not medications that we administer, but medications that people take. And we need to understand a little bit about that as well. In fact, that's an important part of pharmacology, is understanding medications outside of our scope of practice, because many of those medications are going to have an impact on our patients, and some of those medications can have various side effects and various interactions. And so we have to have a good understanding of classes of medications outside of our scope of practice, because that helps us better understand what's going on with our patients, and ultimately better understand how to develop a treatment plan and how to communicate and make sure that we have good continuity of care occurring. So I'm going to focus on talking a little bit about, there we go, the antidepressants, mood stabilizers, and antipsychotic agents. So let's move on to that. So the first major category of antidepressants that I want to talk about are the MAOIs. And an MAOI stands for monoamine oxidase inhibitor. So these are drugs that inhibit the enzyme monoamine oxidase, or MAO. And remember, the two major enzymes that help degrade monoamine molecules in our bodies, of which catecholamines belong, many of the catecholamines. So things like norepinephrine and epinephrine and dopamine, and 5-hydroxytryptamine, or 5-HT, which is also known as serotonin. So 5-hydroxytryptamine, or 5-HT, is also known as serotonin. So what we do is if we inhibit monoamine oxidase, prevents the breakdown of these monoamines, these catecholamines like 5-HT, norepinephrine, and epinephrine, right? And when you have more norepinephrine, you have increased levels of norepinephrine in the central nervous system in the brain, then that can help relieve some of the signs and symptoms of depression. But as you might imagine, that can also lead us to many different side effects. And one of the major side effects is going to be an elevation in blood pressure, right? Because many of these agents like norepinephrine, right, have very potent alpha effects. And there are some very important dietary situations we need to be aware of with the monoamine oxidase inhibitors, specifically foods that contain the amino acid tyramine. Remember, tyramine gets converted into various catecholamines, right? One of the first molecules it gets converted into is dopamine. And then from there, the dopamine can get further modified and gets turned into norepinephrine and epinephrine. We actually we went over some of the pathway for that and some of the enzymes involved in that. And it's actually fairly straightforward. So if somebody eats food high in tyramine, and tyramine is very common in various fermented and pickled substances such as beer, cheese, wines, fermented meats, things of that nature, right? They'll increase their levels of tyramine, and that will cause increased production of things like dopamine, norepinephrine, and epinephrine, and that could precipitate a life-threatening hypertensive crisis, right? So someone on an MAOI having a hypertensive crisis, right, we need to dig into the history and find out if they have a history of eating some of these foods. In addition to that, we want to avoid administering catecholamines to patients on monoamine oxidase inhibitors unless we absolutely have to, because the risk of substantial side effects are going to be very high here. And some examples of monoamine oxidase inhibitors that are still prescribed are things such as Nardil or phenelzine or isocarboxazide, also known as Marplam. As you might imagine, these are not commonly prescribed anymore because the side effects profile is so substantial with monoamine oxidase inhibitors. However, these are sometimes used as secondary or tertiary agents to treat depression that is resistant. So if you have treatment-resistant depression, sometimes the older agents like monoamine oxidase inhibitors can be effective at alleviating some of the depression. So that's where we tend to see that. So these are very old agents, very problematic. In addition to that, there are some natural, quote unquote, monoamine oxidase inhibitors out there. There's actually one here. It's very common here in New Mexico. It's a little cool little flower that will actually be blooming here in the next couple of months, called Syrian rue. And it contains alkaloids that are functional monoamine oxidase inhibitors. And this is also used in certain ceremonial contexts as well. Some of you may be familiar with something known as ayahuasca. And ayahuasca is actually a brew. It is a kind of a thick molasses-like substance. Some people say it's tea, but it's really kind of a thick molasses-like substance. And it is consumed in a ceremonial or religious context. Typically, as far as it's generally not recreational, but it is more for, people that are looking for, spirituality or making life changes, things like that. And ayahuasca, the brew, the drink, if you will, is actually a mixture of two major things. It is a mixture of something called the ayahuasca vine, and that ayahuasca vine contains large amounts of something called NN-DMT, or NN-dimethyltryptamine. So basically what that means is that on the nitrogen, on the amine part of the DMT molecule, there are two methyl groups. That's where the NN comes from. There's one methyl group, two methyl group, both on the ends, dimethyl, and then they are attached to a tryptamine molecule, which is an aromatic ring with a little carbon bridge that comes off of it. Most people just call this DMT. Now, if you were just to ingest a bunch of DMT, because there are many plants that contain DMT, if you were to ingest a bunch of that, what would happen is there are large amounts of monoamine oxidase in your gut. And that monoamine oxidase in your gut would metabolize and neutralize the DMT. And this is probably why we have it in our gut, because many plants contain DMT. And so that would be a problem because, a lot of our diet consists of plants, right? We are we are a very flexible creature in many ways. We're what's referred to as an omnivore. We can eat many different types of food sources. So that by itself wouldn't do it. And so what they figured out was that there was another plant known as the Banisteropus caapi. They take the leaves of the Banisteropus caapi, and these leaves contain what are known as harmine and harmaline, harmine and harmaline. And these alkaloids are natural MAOIs. And so when you mix them together, right, the harmine and the harmaline will neutralize the monoamine oxidase in your gut and allow the dimethyltryptamine to get absorbed into your bloodstream, right? So it's it kind of bypasses first pass by deactivating the relevant enzymes, and the hallucinogenic properties of the DMT occur when it gets into your brain. It crosses a blood-brain barrier, but normally that wouldn't happen because the monoamine oxidase in your gut would neutralize it. And so that is just another connection. Another thing that can happen, because somebody might ask, well, what about mushrooms, right? Somebody takes mushrooms, for example. Well, mushrooms contain magic mushrooms, quote unquote, right? The cubensis species or genus, the cubensis, that contain psychoactive compounds. But what they do is they contain something called psilocin. And psilocin does get metabolized by a first pass, but psilocin is what's known as a prodrug. And so what happens is you ingest a mushroom, the psilocin gets metabolized in your gut and liver, and it actually gets turned into its active form, psilocybin. So again, that's a slightly different way of getting around first pass, right? So you can see it's a very complex relationship. But with that in mind, I just wanted to bring up some examples of naturally occurring monoamine oxidase inhibitors that are sometimes used in these ceremonial religious contexts. And that's important because there are very legitimate dietary restrictions that people who engage in this kind of activity need to adhere to. And if somebody's not adhering to that, there is a high risk or higher risk for side effects like hypertensive crisis and other problems. And this is also why if somebody is going to be involved in these agents, they need to be off of certain medications like antidepressants, because the risk of cardiovascular side effects goes up in that case. All right. So is everybody okay with monoamine oxidase inhibitors and the major issues that we need to be worried about or concerned about as pre-hospital providers? Everybody okay there? All right. Well, let's see. I think I'm going to cut for break here. It's 9:22. Let's go ahead and look at taking a next break, because the next couple of topics I want to cover are fairly complex and there's a lot of material and I don't want to break it up. So we'll break just a little early. But before we break, are there any questions? Anybody have any questions? Make sure there isn't anything in chat. Okay, so it's 9:20. How about we meet back up at 9:38? 9:38. I will see you all then. Back. Are there any questions before we get going again? All right. Nothing in chat. All right. Well, let's move on. So the next major category of antidepressants I want to talk about are what are known as the tricyclic antidepressants, or the TCAs. So let me go ahead and share that with you all here. There we go. The tricyclic antidepressants, like the monoamine oxidase inhibitors, are very old. They've been around for quite some time, since they really were developed out of research done in the 1930s, when the first antihistamines, the sedating antihistamines, were developed, like diphenhydramine or Benadryl, promethazine or Phenergan. And we'll talk a little bit about that. So tricyclic antidepressants inhibit the reuptake of serotonin and norepinephrine. So they do have antidepressant properties, but they also have many other properties associated with them. They are antihistamines. They block H1, H2 receptors. And because their structure is very similar to something like diphenhydramine or Benadryl, and they actually came out of, the tricyclic antidepressants came out of the research that was done to originally develop the so-called sedating antihistamines like Benadryl, diphenhydramine, and promethazine. And we've talked about those in lab a little bit. But remember that diphenhydramine can be given as a slow IV push, be given IM as well as orally, whereas promethazine or Phenergan has to be mixed in 50 or 100 milliliters and given as a IV piggyback over 10 to 15 minutes, because promethazine can be very hard on veins, and if it gets infiltrated, it can cause tissue necrosis. So both diphenhydramine and promethazine are effective histamine blockers, but they also have anticholinergic side effects like the tricyclic antidepressants, right? So remember, anticholinergic is anti-acetylcholine, specifically anti-acetylcholine when it comes to the parasympathetic nervous system. So these antagonize the parasympathetic nervous system. So what do? It causes an elevation in heart rate, that dries you out. It can cause mental status changes. It can cause, right, you to feel tired and lethargic, pupillary dilation, right? All of those classic anticholinergic effects. In addition to that, the tricyclics can also block alpha receptors, specifically in the alpha-1 receptors in smooth muscle, And so this can result in a reduction in blood pressure. And so these patients may be prone to syncopal or near syncopal episodes or dizziness due to low blood pressure. And most importantly, the tricyclic antidepressants are very potent sodium channel blockers. So they act very similar to something like procainamide, for example. And this will produce a wide QRS complex, specifically in the overdose situation. These will produce a wide QRS complex, and that paired with the anticholinergic side effects of these drugs will cause a wide QRS complex tachycardia. So the QRS complex gets wide and the rate gets tachycardic, and that is kind of the classic thing. And this is very problematic. These patients can be very unstable. They can have a critically low blood pressure because their heart is depressed. They have direct myocardial depression. Their QRS is widened out, so they're going to be at risk for life-threatening ventricular dysrhythmias like torsade de pointe. And I want you all to remember the overdose situation. If somebody's overdosed on a tricyclic antidepressant, the primary treatment is sodium bicarbonate. Boluses of sodium bicarbonate, the primary initial treatment. And that does a couple of things. It increases the sodium load of the patient in an attempt to overcome the blocked sodium channels. And in addition to that, the bicarbonate changes the pH. It increases the pH, makes the patient more alkalotic, which tends to shift more of the tricyclic antidepressant drug onto proteins in the blood. So it increases protein binding. And so if you have the tricyclic antidepressant molecules binding to proteins like albumin in your blood, they are then not attached to sodium channels in your heart. And this can also occur within the central nervous system as well. You can have sodium channel blockade within the brain, and that can cause seizures. So you can see tricyclic antidepressant overdose can be very nasty with seizures, wide QRS complex tachycardia, direct myocardial depression, alpha blockade, right? And so you just have the whole myriad of problems associated with these. People can be very, very critical. So some examples of tricyclic antidepressants include things like amitriptyline or nortriptyline. Those are two common examples of tricyclics. Tricyclic antidepressants, like the monoamine oxidase inhibitors, are not typically used as primary antidepressants because their side effects profile, again, and the fact that their therapeutic index is very narrow, may make them less than ideal for many situations. But occasionally they are used as secondary agents when the primary antidepressants, the much safer ones, fail to work or quit working. All right. Tricyclic antidepressants are also used for a variety of other problems, to include treating neuropathic pain. This is a common indication for TCAs. So somebody that has like diabetic neuropathy, right? And or maybe they had a back injury and they have sciatica, right? They have some neuropathic pain. They may actually be on a tricyclic antidepressant to help them with that. And there are some other types of pain, headaches, and other kinds of like headache types of situations that people may be on a TCA for as well. So it's not just used as an antidepressant. So those are the TCAs. The next major category, and these are the most common of the antidepressants, and these tend to be the safest as well. These are the so-called SSRIs, and that stands for selective serotonin reuptake inhibitor. So they prevent the reuptake of serotonin or 5-hydroxytryptamine back into the neurons. So the serotonin gets released, and instead of it getting pumped back in through different channels, like the SERT channel is one major target, these inhibit that, and the serotonin stays out in the synapse for longer. And the profile tends to be much safer with the SSRIs in general. Withdrawal is common though, and it's actually common with all of the antidepressants. If someone's been on an antidepressant for a period of time, it is generally not advised that you stop taking that antidepressant, because you can have withdrawal, and that can have physiological and psychological complications associated with it. Sometimes SSRIs can also increase the suicide risk of patients, particularly within the first several weeks of being placed on an SSRI. That tends to be a critical time as the agent begins to work, and these take weeks typically to begin to work. And the shorter the half-life of the agent, the more likely withdrawal is to occur. So agents like, paroxetine or Paxil, for example, that have kind of a shorter half-life, those tend to be more problematic when it comes to withdrawal. But when we're talking about the suicide risk, within the first several weeks, 2 to 6 weeks of somebody being put on one of these drugs, as their depression starts breaking and they start getting some energy, and they actually develop the ability to create complex plans and to follow those plans out, their actual risk for suicide and self-harm may increase. They may need to be very closely monitored, and this is particularly problematic in children, people under the age of 18, where antidepressants in general can be very problematic in that population. And if they're going to be on an antidepressant, they really need very close follow-up. And that's good history that we need to take into consideration as well. All right. Some examples of SSRIs, paroxetine, also known as Paxil. These are super common. Let's see here. Let me think of some others. Prozac, which was the first of the SSRIs. Wellbutrin, another example. Bupropion. Let's see. Effexor as well. All right, so those are just some examples of agents that fall into the SSRI category. Now, anytime that somebody is on an agent that increases serotonin levels, and this includes tricyclic antidepressants and monoamine oxidase inhibitors, that can increase the risk or a problem known as serotonin syndrome. And serotonin syndrome is just a syndrome of too much serotonin. And so this can cause a few different things. And there are 3 major categories. There's what we call mild, moderate, and life-threatening serotonin syndrome. Serotonin syndrome tends to be mild, and it tends to resolve fairly quickly, but not necessarily always. So with mild serotonin syndrome, patients tend to develop mydriasis, right? Pupils dilated, shivering, sweating, and mild tachycardia. If they have mild serotonin syndrome, typically we will observe them closely. We'll give them benzodiazepines for any agitation they may have. And within several hours, they tend to do okay. Now, with moderate symptoms, you have all the mild symptoms, plus these patients tend to have altered mental status. So they can get very agitated, very disoriented, very excited or hyperexcitable. They can have hyperactivity of the autonomic nervous system. They can have muscle rigidity, tachycardia. Their temperature can become elevated, become very hypothermic. And that can lead to neuromuscular anomalies like tremor, clonus, right? Hyperreflexes, right? So in this situation, not only are they going to need close observation and benzodiazepines, but they are going to need to stay in a monitored area. And you can give drugs that block serotonin, like cyproheptadine, right? These are serotonin blocking agents. And then the life-threatening manifestations of serotonin syndrome are patients have delirium, so they have severe alterations in their mental status. They are hypertensive, they're hyperthermic, they have muscle rigidity, and they have tachycardia. All right. These are patients that need intensive care unit monitoring, beta blockers like esmolol, nitrates like nitroprusside to get their life-threatening hypertension under control, actively cooling them. All right. And even sedating them with larger doses of benzodiazepines and possibly paralyzing them, right? Skeletal muscle paralysis, right? To relax those skeletal muscles so they're not contracting and causing all that heat buildup. And imagine the risk of rhabdomyolysis, acute kidney injuries, and acute lung injuries are going, the risks of those will be much more elevated in the setting of life-threatening serotonin syndrome, right? So we may need to paralyze and intubate these patients. Problem with this is this can look a lot like, malignant hyperthermia. It can also look a lot like heat stroke, right? And so history is going to be really important. You know, have somebody with these signs and symptoms, like what's the cause? What's the history, right? Is this somebody who was, recently placed on an SSRI, or is this somebody who is, experiencing a more classical heat injury, right? You're going to have to try to put things together. All right, so that's serotonin syndrome. We're going to come back to this in just a minute, because this looks a lot like another syndrome of another constellation of problems that another class of drugs can cause. But we will compare and contrast those when we get to them. So the next major category of drugs I want to talk about are what are known as the antipsychotics. So antipsychotics are drugs that are used to treat psychosis, and psychosis, we'll talk about psychosis and some of the various mental health disorders surrounding that in the medical block in more detail. But psychosis generally is a loss of contact with shared reality, right? And so classically we see hallucinations, auditory, visual hallucinations, for example, but psychosis has lots of other problems associated with it. We call these the negative and the positive symptoms of psychosis. So a lot of people with psychosis also have a hard time with society. They tend to be very withdrawn. They have difficulty in social situations. They can be depressed and anxious, as well as having the hallucinations and so on. So it's actually psychosis is actually a very complex concept. But antipsychotics are agents that are used to treat psychosis. So things like schizophrenia, psychosis that can occur in the setting of bipolar disorder, sometimes even depression. People who are incredibly depressed can become psychotic as well. So psychotic does not mean murderous, ravenous, murderous intent, right? If we say somebody's psychotic, that means they have psychosis. There is also something called psychopathy and psychopaths in that, but that's a very different thing. That is not psychosis. So being psychotic is a loss of contact with shared reality. And there are two major categories of agents. They're what we call the typical antipsychotics. These are the kind of the OG, these are the older ones. And then there are something called the atypical antipsychotics, and these are the newer generations. The typical antipsychotics are very potent dopamine blockers. They block the effects of dopamine in the central nervous system. And these include things like Haldol or haloperidol and Thorazine or chlorpromazine, right? And so, yes, promethazine is a chemical cousin to Thorazine. And so it does have lots of properties, right? The crossover of effects is very similar between promethazine and Thorazine for that reason, right? So these typical antipsychotics tend to be very potent dopamine blockers. And in fact, promethazine is a dopamine blocking agent. You give somebody promethazine, that patient is at a higher risk for some of the problems that we're going to talk about that are associated with antipsychotics. All right. Dopamine is also very important in different movement pathways in your brain. The nigrostriatal pathways, for example, are neurons that start in the substantia nigra and go into the striatum, and they help regulate movement. And so when you block dopamine in the central nervous system, you increase the risk of causing a so-called movement disorder. And we'll talk about what some of these movement disorders are. The newer agents, the so-called atypical antipsychotics, are not as potent of dopamine blockers and actually block serotonin as well. So the risk of movement disorders is not quite as high with the atypicals, but it's still there. And these are incredibly common. And these include drugs like risperidone, also known as Risperdal, olanzapine or Zyprexa, quetiapine, also known as Seroquel, aripiprazole, known as Abilify, and ziprasidone, known as Geodone. Those are just some examples. And these agents are sometimes also used not only as antipsychotics, but they might be used as what are called mood stabilizers, right, in people that have bipolar disorder to help prevent them from swinging between mania and depression as much. So these antipsychotics can have some other indications as well. All right, so what happens when we block dopamine in the central nervous system? Well, this increases the risk of these various what we call movement disorders. And there are a few major categories. The first is something called akathisia. And akathisia is someone who is incredibly restless, right? They have to move, they can't help it, they can't stop it, and it's not some lack of willpower. This is actually, right, a dopamine mediated problem. So these patients become incredibly restless. They need to move about, right? Pacing, walking, toe tapping, rocking while seated, right? And they can experience severe distress if they get restrained or they're not able to move, all right? So that's akathisia. There's also something called Parkinsonism, right? And Parkinsonism is just that. These are people that present kind of like they have Parkinson's disease. Why? Well, Parkinson's disease is a disease that involves the loss of these dopaminergic neurons, loss of neurons in the substantia nigra, for example, and that produces a movement disorder. These patients have tremors, certain muscle rigidity, very slow movement. It's very disorganized, very uncoordinated. All right. They have difficulty moving muscles in their face, and so they kind of have a flattened out affect, and their face just kind of looks like a painting of a face without any emotion on it, or what we call a masked face. difficulty moving their tongue around and swallowing in some cases. Their posture can get dropped down and stooped down as well, right? And so when we block dopamine chemically, this can cause many of the same signs and symptoms you'd see in Parkinson's disease, all right? Because it is a anti-dopamine problem that we run into. And then the two major ones that we run into are what we call tardive dyskinesia and dystonia, all right? So tardive dyskinesia and dystonia, all right? And the signs and symptoms are very similar between these, but tardive dyskinesia, I just want you to remember that this tends to be a more chronic problem, and it may not go away. It may not resolve. So this is very common on people that have been on antipsychotics for an extended period of time. So they tend to have involuntary movements, tends to involve the oral facial region, the tongue, very common with the tongue. You've seen somebody who's been on an antipsychotic for a long period of time, and their tongue is kind of moving abnormally, and it's moving in and out of their mouth, or they're smacking their lips and they're moving their head a lot. That is classic tardive dyskinesia, with that lip smacking, chewing, tongue protrusion. Very, very common findings. The symptoms are not painful, but as you might imagine, they can be very embarrassing and in very problematic in social situations, further alienating these people, further adding to the negative symptoms that they may experience, right? Now, dystonia tends to be more of an acute problem, and it may resolve. So an acute dystonic reaction can look similar, but it tends to occur acutely and it tends to resolve. And these patients have some of the same side effects, but what happens with dystonia is they have sustained involuntary muscle contractions and spasms. Often involves the back, the neck, the jaw. They can get like their neck, right, muscles in their neck spasm, and they can get what's called torticollis. The spasms are associated with distress. So this tends to be more uncomfortable and can be painful, unlike tardive dyskinesia, which is not painful. All right, these people can have difficulty with ambulation, breathing, head turning, speech, and swallowing, right? So it's an acute dystonic reaction. So how do we manage? Well, in all cases, managing these various movement disorders involves getting them off of the drug that's causing it, or decreasing the dose if possible. All right. Sometimes Botox or botulinum toxin can help with the more longer term management. But when it comes to an acute dystonic reaction, anti-muscarinic agents are going to be very helpful, because there is an acetylcholine dopamine mismatch that's going on in the central nervous system. And so kind of the frontline agent for treating a dystonic reaction, an acute dystonic reaction in a patient, is to give them Benadryl. Give them diphenhydramine. Remember, diphenhydramine, not only is it a potent antihistamine, but it has potent anticholinergic effects. You remember, muscarinic receptors are one of the two major subtypes of cholinergic receptors. There's the nicotinic and muscarinic. So you block the muscarinic receptor specifically in the central nervous system to help relieve the side effects of an acute dystonic reaction. So let me ask you all the question: could you give somebody promethazine or Phenergan if they're having an acute dystonic reaction? Would that be helpful?
No, because it has some of the same effects as the meds that we're trying to overcome.
Absolutely. Yeah. So promethazine is an antimuscarinic agent, but promethazine is a potent dopamine blocker, right? D1 and D2 receptor blocker. And so promethazine can actually cause an acute dystonic reaction. In fact, the worst acute dystonic reaction I've ever taken care of was in a patient that received Phenergan for I think she's having a migraine headache. And we were treating her migraine. She got promethazine and ended up having an incredibly severe acute dystonic reaction. Good. So I'm just going to provide you with a list of agents that can cause these movement disorders. And you can see anything that modulates dopamine, right, can do this, right? Lots of the antiemetic agents like droperidol or metoclopramide, known as Reglan, it's an agent we can potentially give, promethazine, right? All agents that we can administer. All of the antipsychotic or the antipsychotic agents involved with dopamine, right? Even the atypicals can cause this, right? So there are a litany of agents that can do this. So just a quick review here, and this is just the link for the little boxes that I shamelessly stole here. So just a review, monoamine oxidase inhibitors, we're worried about tyramine-containing foods, life-threatening hypertensive crisis. Tricyclic antidepressants, we're worried about sodium channel blocker toxicity, treat that with bicarbonate. SSRIs, and in fact, all of the antidepressants, we're also concerned about serotonin syndrome. Right? And antidepressants, we're worried about the movement disorders, specifically acute dystonic reactions and tardive dyskinesia. But the acute dystonic reaction tends to be the more immediate thing that we run into. And I just want you to remember that Benadryl is kind of the immediate action for that, right? All right. So let's move on and talk about yet another disorder that is common, that we're not common, but the risk for this disorder tends to be higher on people that are receiving antipsychotics, and that is something called NMS. And NMS stands for Neuroleptic Malignant Syndrome. So Neuroleptic Malignant Syndrome, NMS. And it looks an awful lot like Serotonin Syndrome, but it's not, right? So if somebody is on an antipsychotic and maybe their dose has been increased or they're placed on an antipsychotic recently, or an antiemetic agent that has dopamine blocking properties like metoclopramide, also known as Reglan, or promethazine, Phenergan, right? They can have altered mental status, muscle rigidity, hyperthermia, elevated heart rate, and blood pressure, right? But this is NMS, and these treatment, we need to increase dopamine levels by giving them dopamine agonists like bromocriptine, all right? And the recovery from neuroleptic malignant syndrome tends to be prolonged, all right? The recovery tends to be prolonged. These patients tend to be sick for an extended period of time, and the side effects are very similar to serotonin syndrome, right? You got to be worried about acute kidney injuries, rhabdomyolysis, life-threatening hyperthermia. And these patients, like their muscles can seize up and they can just be like a seized up immobile object. And this is sometimes referred to as lead pipe rigidity, right? They're just like a rigid metal pipe lying on the floor. And in fact, I've only seen this once in my entire career, and it was actually when I was a nursing student working on an inpatient psychiatric unit at a veterans hospital, where a patient developed neuroleptic malignant syndrome, and that's what they look like. They're very altered. Their mental status is altered. They had a high body temperature, and they were just rigid in bed. They're very sick, and we ended up having to transfer them into an intensive care unit, and I'm not sure what happened to them after that. Whereas serotonin syndrome has a lot of the similar signs and symptoms, but these patients tend to recover fairly rapidly. We give them a serotonin blocker, get their body temperature down, give them benzodiazepines, and they tend to recover fairly rapidly. Whereas neuroleptic malignant syndrome, the recovery tends to be much more protracted. And then, of course, malignant hyperthermia is a very sudden onset, rapid increase in body temperature, rapid increase in end-tidal CO2. And this is in the setting of typically inhaled anesthetics and depolarizing neuromuscular blockers, right? And we talked about that already, how that is a calcium problem, right? You've got receptors for, you have impaired receptors, aridine receptors in your muscles, and calcium ions aren't able to move properly through those, and the cells have to create a lot of ATP, and that releases a lot of heat, right? But treating that requires a special calcium antagonist known as dantrolene, right? That's the treatment for malignant hyperthermia. So you can see you have 3 disorders that have similar signs and symptoms. How do you know what to do? You need to get a good history, right? This is where history is so important, right? Because if this is somebody who was placed on a new antipsychotic or their dose was increased, and now they're having all these problems, you want to be thinking, is this neuroleptic malignant syndrome? Or is this someone who was started on an SSRI, or maybe the dose got increased? Okay, maybe this is serotonin syndrome. Or maybe this is a patient where the flight crew intubated them and they administered succinylcholine, and now they're having these signs and symptoms. You want to be thinking malignant hyperthermia. Similar signs and symptoms, but very different, right? Very different specific treatments. All of them are going to get supportive care and like active cooling and all that. But, you know, dantrolene is what we use for malignant hyperthermia, and there are other agents involved for the, you know, serotonin blockers or dopaminergic agents for the various disorders. So, right, like bromocriptine, for example. All right. So any questions over those concepts? All right. The last major category of agents that I want to talk about today are what are called the mood stabilizers. And mood stabilizers are commonly used to treat what's known as bipolar disorder. And in bipolar disorder, there are actually different subtypes. There's bipolar 1 and bipolar 2. But with bipolar disorder, the problem is it's a mood disorder. And so someone's overall mood can shift between 2 poles, between what's called mania, where they can get very manic or sometimes hypomanic, and depression. And mood stabilizers help to prevent that from shifting back and forth between those poles. It kind of stabilizes that a little bit. Mood stabilizers tend to be much better at keeping them out of mania, but the depression often needs to be treated with antidepressants. And so you can see people that have various psychiatric disorders might be on multiple categories of medications. I also just want to mention that many of the anti-seizure agents are also used for their mood stabilizer activity and vice versa. So some of these mood stabilizers may be used as anti-epileptics to treat epilepsy and seizure disorders in general, right? For example, lamotrigine, carbamazepine, valproate or valporic acid, right? These are all also used to treat seizure disorders, right? So keep that in mind. So I'll just give you some examples of common mood stabilizers. Lithium, one of the oldest, all right, And then some of the common side effects: headaches, nausea, vomiting, dizziness or drowsiness, tremors, very common with lithium. You get the lithium tremors. Increased thirst, because lithium actually interacts with hormones that impact your kidneys, like antidiuretic hormone, right? And so kidney dysfunction or chronic renal insufficiency tends to be common in people that take lithium for extended periods of time, and sometimes they actually have to go off of the lithium because their underlying renal function is so impaired, and they can get rashes as well. Valproate, valproic acid, sometimes referred to as Depakote. Headaches are common, bloating or swelling, bleeding gums, and an overgrowth of the gums as well. It's very common with this. Delusions, joint pain, weight loss and gain. And I will say, for antidepressants and antipsychotics, as well as mood stabilizers, weight gain and sexual dysfunction are very common side effects. In fact, this is sometimes why it can be so hard to adhere to treatment, because the side effects can be so debilitating, right? You've gained massive amounts of weight, and I have no sex drive, or a male, you may not even be able to have an erection because of these medications, and that can alter your life so much that some people may choose to go off their meds and then deal with the consequences. And so this is a very, a lot of complex interplay of things going on here. Lamotrigine or Lamictal, right? Loss of balance, visual problems, diarrhea and constipation can impact the menstrual cycle, joint pain, weight control problem here. Carbamazepine, Tegretol, dizziness, abnormal thinking, difficulty speaking, dry mouth, constipation, uncontrollable shaking. So you can see that there are lots of side effects with these various agents that you need to be aware of. And in some cases, when you're taking care of somebody, their underlying problem, their complaint, may actually be a side effect of a medication, or it may be a medication interaction, and an interaction between two or more of the medications they're on. And there is a concept known as polypharmacy. And this is where somebody is taking two or more medications, right? And we need to be aware of this as well. And we need to always think about this, like, what are the medications they're on? And you can go to your little Epocrates app, and you can put the patient's med in, and it will do a cross check for interactions and give you a list of, hey, these are the common things that you might expect to happen on a patient that's taking these drugs. And it'll tell you, hey, these 2 drugs or these 3 drugs tend to adversely interact in this way. And then you go, could this account for some or all of the patient's signs and symptoms, right? It very well could. Medication interactions and side effects are a very common cause for, or a common reason why people access the healthcare setting. And people that have psychiatric disorders that require this kind of treatment tend to use the healthcare system quite a bit, right? They tend to use a lot of the resources. And so these can inherently be very complex people to take care of in general. And hopefully you can see there's a lot of interplay going on here, both psychological and physiological, that we need to kind of take into consideration and kind of be aware of. All right. Any questions over any of that? Any questions over anything we've covered so far? Make sure I didn't miss anything in chat here. Okay, well, I think we've gone over plenty of material today. So what I'm going to do is I'm going to cut it off here. Remember, bring page 1 of the dosage calculations part 2 with you to class today. And the second part will be due tonight by midnight. There will be some additional videos and quizzes that are going to open up this week. I believe there are still some other modules that we need to get through. I know we've got antibiotics coming up and some additional cholesterol, lipid, and diabetic agents as well. And those will be opened up a little later on this week. So be on the lookout for those. Well, if there aren't any questions, I think I'll cut it off here, and I will see you all in lab a little later on this afternoon.
Chris?
Say that again?
What time are we meeting up at? Same time, 2:30?
Yeah, same time.
Same time. Okay.
Yes, sir. Yep, same time in lab.
Cool. Thanks, Chris.
Thank you all. Take care. See if we can